first.
Okay.
Okay. Good morning, good evening, depending on where in the world you are. Welcome to another episode of Intellectual Calisthenics. Today, I have the honor and privilege of having Dr. S.K. Mishra on as my guest. So, Dr. Mishra is the professor and head of the Department of Endocrine Surgery at the Sanjay Gandhi Postgraduate Institute of Medical Sciences in Lucknow, in India. But more importantly, Dr. Mishra is the nodal officer of the Telemedicine program at SGPGI. And I'm really excited to have him here today because he has extensive experience in telehealth. And today's topic is telehealth advantages and challenges in India. So, Dr. Mishra, I'll hand over to you because you have such fascinating stories. So, how did all this start at your institution?
Thank you, Dr. Sabnam, to giving me the opportunity to speak about my experience as well as the experience in this country, how the telehealth is being happening. Yeah, well, it takes back me to the year 1999 when I started the first telemedicine experiment as a kind of passion to see that how this can help in connecting educators with the students. So my specialty was endocrine surgery. So earlier I used to have physical face-to-face postgraduate course inviting students from many parts of the country, and wherein I used to invite a lot of experts to talk about endocrine surgery. But I realized the participation is not so good. So I thought, why not I talk of something, some technology or something which can really connect. And I got the opportunity to visit the Strasbourg in the France in the year 1997 to attend a workshop. And I realized that there is a video conferencing system going on there. That was the very primitive days of video conferencing, and very few institutions has that facility. So that institute is called European Institute of Telesurgery, that is located in the Strasbourg in the France. And while attending a workshop there on minimal access endocrine surgery, I happened to see that facilities. So then I got the idea, why not I talk about this video conferencing to connect the participant in the work of which postgraduate course that I've been hosting every 2 years at my place. So 99 was the next schedule of postgraduate course. So I read a lot about these technologies and tried to look for who can help me out to achieve my dream, and realized that I had to contact the telecom department. And those days, not many private operators are there in this country. Only the Indian telephone industries, one company which produce equipments or import equipment and sell it in India, and another telecom company is the telecommunication department of the government of India, Department of Telecommunication and Information Technology. So in that, I approached those days it was called like Lucknow Telephone. I belong to a place called Lucknow in the state of Uttar Pradesh, and it's called Lucknow Telephone. So I contacted the chief general manager and explained to him my situation. And after a lot of persuasion, in February 1999, I could convince him that he will be provide me very broadband kind of telecommunication facility. Those days you didn't have this very high speed internet. We used to have something called ISDN,
Yeah.
Integrated Service Digital Network. And for that, I need to have a telephone exchange which should be digital, because those days the exchanges were crossbar exchanges. If you have seen the old type telephone exchanges, they used to plug in and plug out like that.
Yes.
They should do that. So they said that there is no question like that. But however, you have microwave technology. So I read a lot about these things. And for a surgeon who is explorer, so I had no problem to get the knowledge. And I then again pursued this. After 3 or 4 visits, gentleman there saw that he cannot escape from my demand. So ultimately agreed. But unfortunately, my infrastructure was not so conducive. My institute is located little away from the main city, and the digital exchange is required to have ISDN. And the digital exchange is 70 kilometers from my place. For digital exchange to provide you with ISDN, you should have minimum 1 kilometer radius of the exchange. But somehow, with a lot of persuasion, the chief general manager agreed to put some boosters, and he could manage to give me the thing, ISDN. So I took 384 kilobit of ISDN bandwidth as the minimum bandwidth required for optimal video conferencing. But then, what about the equipment? In those days, you don't have sophisticated equipment that you see today, and today you have the pleasure of not having any equipment,
Yeah.
using our own devices and doing it. So I saw after 20 years of my struggle, this is the world that where we are heading for. I don't know what not is there in the next. So, so I could manage to convince some of these companies. There are two companies only. One, the government company, Indian Telephone Industries. They used to market the product called Beacon, which is made in Israel. In those days, many of these video conferencing companies are based in Israel, whether it is PictureTel or Beacon or then Rad Vision. So those companies are not there nowadays. So they have been split out, and future also will see not this company. Future will see these software companies. So I could manage to get a desktop video conference system, which is a demo piece with the Indian Telephone Industries Lucknow office. So we tested. Then the workshop was supposed to do address the minimal access surgery. So that means I have to show the integration of the endoscopes with this video conferencing system. Funny, all these things happened. There are many stories about this thing, how it happened. But from February to October, that is the scheduled month of postgraduate course, we could achieve. And that always gives me opportunity to tell the youngsters, see, if you have a vision, if you have a dedication, you can achieve it. So ultimately, in October, last week of October, we conducted this minimal access endocrine surgery workshop, wherein I invited five of my friends from Europe, endocrine surgeons, and they came here and we could demonstrate the live surgery procedure in the using ISDN 384 kilobit and using the desktop system with a headphone like that, and we could connect to some centers in India far away, around 2,500 kilometers, somewhere 50 kilometers like that we could do it. So it's a fast experiment where you could see the feasibility, so opportunity to go ahead. And the same event, actually, we invited our chief minister of the state and I requested him, just give me some money. And in terms of Indian rupees, I can tell it, it is 6 lakhs of rupees, 600,000 Indian rupees. And just to cover up a desktop video conferencing system I can buy. And the money, half of the money was kept for ISDN. Those days, ISDNs are very, very expensive, and 120 kilobit into 3. I have to get 384 kilobit. So I kept half of the money for the bandwidth cost, and half I could invest for the desktop system. And that's the way actually what I did is then, what about the remote center? Video conference cannot occur solo. You need a partner to do it. And those days, no institution, medical institution had the video conference system. Fortunately, there is one institute which is very much supported by the overseas philanthropist, that is called Amrita Institute of Medical Sciences in Kochi. So
Coaching.
they had the luxury of many American disciples. So they had a system there, a video conferencing, very luxury video conferencing system called PictureTel, and I could connect them and did some experiment with this thing, just like education. So my starting point was education and sharing experiences with surgical skills, etc. So people always tell me that I am just like Lord Hanuman, which is an Indian kind of a religious
Yes.
structure. Because when Lord Hanuman was born, he wanted to swallow sun. I don't know whether know the story or not. So I jumped into telemedicine and I wanted to solve the high-end application of telemedicine, that is telesurgery. I mean, in Canada, this telesurgery is very popular because people from mainland, they connect to Newfoundland to do robotic telesurgery and
Yes.
consultation, etc. Those things are very familiar with that. That is the story I started. So this okay, equipment that was sanctioned by the government, chief minister. So I started using it and did a little bit of experiments, just exploratory nature. The next thing I did, it again a very difficult task of how to remotely monitor the health. That is the real application of
Yes.
telehealth that I did it for the pilgrims used to trek to Kailash-Mansarover.
Oh,
So my team, I consider one engineer, one doctor, one of my resident, I convinced them to trek along with the pilgrims. So
wow.
if you remember, if you know what is the system those days, that the pilgrims they go in batches. They will go
Yeah.
in batches of 20 or so, and they're
Yeah.
accompanied by a medical officer
Yeah.
and also accompanied by a government representative with a wireless satellite phone.
Hmm.
If you know the Inmarsat company, Inmarsat company is a satellite-based
Okay.
communication company. So they use Inmarsat handsets, and which gives maximum 64 kilobit of bandwidth. So, so what I used to do is I started this video conferencing using I don't know whether you know about it called net meeting. It gives very
Mhm.
stamp size.
I'm not familiar.
It's a, if you talk of those things, people say that you are from 100 years ago talking about that. So this is I used ordinary telephone that's called PSTN. It's called Public Switch Telephone Network. The
Okay.
ordinary desktop phone. Many people don't have it now actually. So this is the desktop phone. So for that, I got the first the lab of telemedicine was created in my office. Sometimes I'll share you some photographs of those. So I replaced all my office stuff, and I kept these computers and connected the ordinary telephone with there's called DP box. The DP box is the box where you put like rosettes. So if you remember old telephone systems, from the pillar of the telephone, you used to get a connection. There's a
Okay.
DP box. So that
Oh,
that DP box has 6 connections. So you can provide 6 household the telephones.
oh,
So that DP box I connected in my office, and I got a special line from my telephone exchange of the hospital to my office. So from there, I can get the direct access to the copper, so that at least I'll get a little better bandwidth rather than using my ordinary desktop telephone that I provided by the institute. So then this I used for connect net meeting, which gives me a stamp size video conferencing, just run in 5 kilobits of bandwidth, 5 kilobits,
oh,
505 kilobit, and it goes to very kind of you see that slow video like that.
okay.
So but I could see my colleagues. They are traversing to the Kailash-Mansarover. So what they did is, Kailash-Mansarover, you have to cross China border. So
Mhm. Yeah.
before China border, we can operate such kind of electronic devices. So I sent them some of the ECG and some of these things to transmit me, and some video I can transmit. So just a test case, how it is happening, because they take a stressful kind of exercise by trekking the mountains. So the first part was called Dharchula and Pithoragarh. Those are the points, camp points. So what they used to trek, then they rest, then they trek, then they rest, like that. They used to go like that.
Oh,
So
okay.
all the camps, very interesting story. So the camps where they are had telephone, where their telephone system is there, that's called PST, not in telephone. Till that point, I could demonstrate transmission of this net meeting video and also some waves of ECG. We cannot interpret anything from that, but I could see the transmission of some wave of ECG. Then, after some time, there is no telephone, because then the real uphill task across mountain. Then in the camps when they rest in the evening, then I use Inmarsat satellite phone, which gives 64 kilobit of bandwidth, and obviously the transmission is not that good, but what I want to send the message to you is that we started very difficult experiment well much before my experience with the journey of telemedicine. So we could demonstrate, and of course after the Indian border, China, then we could not do that actually. And this has a lot of public health importance. So when I got that experience, so 2001 is the watershed in terms of grant that made a lot of change in creating infrastructure. So that time I applied for a grant to our electronic and communication ministry. That time both are combined. The telecommunication and IT were combined ministry. So I asked for a grant to the MC Department of Information Technology and Communication, IT, and they gave me a grant of Indian rupees 56 lakhs rupees
Oh,
around. It's
wow.
big money in those days, in the
Yes.
year 2001. That is my first, excuse me, that is my first external agency grant I got for the telemedicine experiment. And when telemedicine was hardly realized by many people, even the reviewers also don't know how to evaluate this proposal. 2001, if you know, the last mass gathering that occurred in the city of Allahabad, the Prague we call it nowadays,
Yeah.
at the junction of
Okay.
river Jamuna and Ganga, and we used to have Maha Kumbh Mela.
Maha
Maha Kumbh Mela. This is a where that is occurs in once in 12 years
Kumbh.
in that place. So there a lot of gathering. It is millions people they gather and they stay there for months. So it spans over 2 months there, exactly 1.5 months or so. So I proposed that can we really cater to this population when they are in a very awkward situation? So can you practice telemedicine in extremes of environment? That is the theme. And there again, we installed the ISDN. That time I had little experience, so I could really plan properly and in very short period of time. Which, as you know, the granting agencies give a grant and give a very small time to deploy it. So I got
Yes.
yeah, yeah. So, but somehow I had some contact with not many companies are there those days, but there's one company in Ahmedabad, Online Telemedicine Research Institute. I don't know where from that gentleman cropped in, and so we could jointly prepare, and we're almost ready just to get the order from the government. That's why he could send by aircraft all these equipments. As when the grant was sanctioned, before money came, he just sent it and got the money much later. And with his manpower and everything, and we deploy within 48 hours. In the bare sand, there's nothing. The Ganges and Jamuna River is bare sand. Because the government makes a temporary district there, this
Mhm.
temporary district-like thing, and provide all facilities. So I'll send you some photographs later. So how we did it, that experiment there, I could see that how good, beautiful pictures of the hematology smear, ECG, X-rays we have transmitted from that remote region, and we could give consultation to this place and remote monitoring of public health in terms of water quality evaluations and all these things. We did it, and we put five nodes across Lucknow, because to monitor the Mela, we put a center in the secretariat to monitor the water quality. They get everyday report by fax. They made it to a digital format, put it in their public health office. Then one I put it in my institute to give teleconsultations. So one I put it one called Medical College in Allahabad Medical College, because fast emergency goes there. So we are all connected, all five. This is the first enterprise telemedicine network I set up, and that gives you real confidence. Okay, I can go do major projects. So this is way back in 2001. It lasted for 6 weeks. Then this one of the component was disaster. Can you mitigate disaster, or can you get disaster preparedness and give short disaster? So when we get a large kind of gathering, we expect a lot kind of disasters in terms of the infectious diseases, in terms of accidents, trauma, etc. So all these things were covered in this project. That time in the state of Odisha, in the eastern part of India, there is a flood. So
Okay.
at that time, this Mela was finishing. So I diverted one particular node to that state to deploy it in one of the medical college, so we can support them if any problems occur during their plot there from our institute. Our institute is a little bit of higher level, super specialty institute, and I had the scope of shifting this node there because it was partly covering disaster. So I could show that is a flood, and I could deploy there. I took care of their manpower, all expenses, so that we could start immediately. Then in the state of Odisha, I really are very indebted to the one of my colleagues. Was I could convince him, and they see that a good career for you, additional career. He incidentally is a surgeon, so he agreed. And I mean, down the line now, after 15 years, I remember that after 15 years, it's almost like 20 years or 19 years. He is the chief advisor to the government of Odisha in terms of telemedicine. I mean, so many
Oh,
things happened
wow.
in all these years. So, of course, he supported me that time. As I told you, telemedicine is a collaborative technology, it's a collaborative venture. Without like-minded partners, we can never perform telemedicine. That's exactly I'm telling you. So then I started a lot of experiment with Dr. Mahanti, Professor Mahanti of SGPGI Medical College, Cuttack, Professor of Surgery. We transmitted live surgery, as I told you, the postgraduate courses. Then
Yes.
every 2 years I used to transmit. Then every year used to have a lot of these clinical meetings discussing interesting cases. When there is interesting surgery, I used to transmit that to their centers. So that became my experimental field position to do all my kind of experiment. Then down the line in 2003, I had some experience started with satellite. All along I was using ISDN. So ISDN has inherent limitations because this is a technology which has problems of its own. And if you remember, ISDN very quickly vanished from the scene because it has a lot of deficiencies
Oh, we are having a little bit of challenge with your audio, Dr.
called
Mishra.
Indian Satellite Resource Organization. Hello.
Yes, I think we had a little bit of a
Can you
challenge.
hear me
Yeah,
now?
I can hear you now.
Is it okay now?
It's it is off and on, but I think when I can't hear, I'll ask you to repeat. So you were
Okay.
saying that the technology then was very different, and they had to abandon it because it wasn't really doing the job. Now, Dr. Mishra, I'm just going to interrupt you here because you have achieved a lot of things in, like, when you said that you moved from Allahabad to Orissa because of the flood, you made it sound like it was very easy to do. What were the challenges? You described all the challenges, but you said the advantages were because you had wonderful cooperation from a lot of people. So, and this was 2001. So it's not like communication was as simple as, us sending a WhatsApp message or something. So what do you think? I know number one is, of course, your attitude of getting things done. What else do you think contributed to you being able to, implement that? Because that is not a simple thing to implement, right?
Yeah, this kind of experiment, actually, this kind of initiative, what you can say, requires a lot of dedication, a lot of perseverance, and communication ability, and power of convincing others to share your vision. So see, if you, as I told you very earlier part in 1999, I had to visit this gentleman in the telecom office. Just imagine from a hospital, I'm going to a telecom office, sitting in front of the officer there who is the decision maker to get an appearance to explain. And two visits, I just take a tea and come back with all pleasantries. Only in third meeting, I get an opportunity to present my ideas. So it takes time. I mean, later on, the same gentleman was so convinced. He said that if ISDN fail, I'm going to provide you microwave. I have to do it any case. I mean, as I told you, if I talk about the history of telemedicine that I have experienced, it can become a book. And
Yes.
anyway, when I retire, I can think
Good.
of writing that book. But the issue, I didn't get time to even think writing a book because I had no time working on this thing. So I'll very briefly make this conversation to sort in terms of evaluation, because that's my personal experience. That's not appear here, but you got some little bit of flavor to how things started. Actually, it didn't start so rosy. I have to struggle for that. But the message that you got it, you require a good partner who understand or who share your vision. Then everything falls apart. You can do it, everything, no issue. Then the national programs that started, actually, I must tell that now the national program started how it started actually. Then the Indian Satellite Research Organization, because the ISDNs had little problem in terms of the getting consistent connectivity. So then the satellite companies, our Indian government company called Indian Satellite Research Organization, ISRO. You know, India is in almost 10 leading countries in terms of
Yes.
satellite technology.
Yeah.
So we got satellite communication to connect centers for telemedicine. 2003, the first deployment was again in Odisha, and by the time I got a little friendly in ISRO, and that are not many centers are there. So they used to take me and make a showcase for different states to talk about telemedicine. And in turn, I used to get their favor in deploying telemedicine, which is my dream for the country. So we had that time deployment of SATCOM-based telemedicine in many states in the country, where the ISRO, the Department of Space, Government of India took all the expenses from their side. Again, I talk the downside of that. You find not much of utilization of satellite-based technology because it has inherent problem of getting only 300 odd kilobits of bandwidth.
Mhm.
Now, in 2003, it's fine. In 2005 or onwards, really the number of takers to adopt satellite, though everything cost is involved and covered. And second thing is that company was that government agency did not provide any support in terms of maintenance. So one has to remember that the challenge again. I am citing the challenges in a story wise. So the challenge is if you do not give a technically competent manpower and deploy a technology in one institution, then it's obviously going to
Yeah.
fail 100%. But when you won't approach any government or any hospital, they'll be very happy to get a technology like that, which is very innovative. But that's fine. But what about after the equipment is
Yeah.
deployed? You do not have any mechanism to sustain it. So there, the satellite deployments really did not work well because there are no manpower to take it forward. Though they used to support in terms of maintenance, everything, but down the level, in the ground level, who is there to operate it? So
Mhm.
that is the story of a satcom based telemedicine. It didn't really work out well. One, in terms of the sustaining the effort at the ground level. Second, in terms of the manpower and the bandwidth. The bandwidth is not so good. So people become more demanding in terms of bandwidth. They need more bandwidth for because they become more ambitious. They want more quality. So the
Yeah.
qualities are they don't provide the qualities. So in that way, the satellite technology did not last long. And another thing that why people did not prefer satellite is that time by 2005 or so, the internet has already chipped in. So when
Mhm.
the IP technologies came in, then satellite technology has gone down. So people have the facilities. Even I have facilities now also, but it didn't work out. But it did help us in the initial period when we did not have this internet availability in all places. Because
Yeah.
they used to give that facility in many remote areas, and even we have a satellite deployed in our bus. So like that. So when the internet phase came, then that time the government policy also changed. In 2006, here I'd like to take back a little bit earlier, because when in 2001 we had a grant from Government of India, we organized a national conference. It's called the National Conference on Telemedicine, wherein all like-minded people who attended this meeting in Lucknow, we decided to make a society for scientific
Okay.
promotion and advancement of telemedicine. It's called Telemedicine Society of India. And
Oh,
this
wow.
Telemedicine Society of India was launched here in Lucknow with a contribution of 100 rupees by all the participants as a token amount showing commitment. So our founder members. And then this society was again have the first conference of society 2002. Again, we did that organization here in Lucknow. Then slowly this came, grew up. And 2006, there is an international conference in Bangalore, where our ISRO, Indian Satellites Organization, organized that. At that time, they could bring in the government Ministry of Health. At that time, the user ministry, that is the health ministry, came to picture. Otherwise, before that, it's the satellite ministry, and
Okay.
another ministry is called the Information Technology Ministry, as I told you. They
Yeah.
gave me the grant in 2001. So they used to spend money in R&D. So broadly speaking, the electronic ministry, IT ministry gave grants to develop technology and did pilots, and ISRO, satellite industry, they gave us satellite communication. So these two technical ministries really played a big role in developing technology in India. Then the Minister of Health formed the first task force in 2006 after attending the conference in Bangalore. And that is the year we got our registered Society of Telemedicine Society of India. We registered the society then.
Wow.
Then year after year, the Telemedicine Society meeting is going on, and this year is the 20th year of our Telemedicine Society, and we are organizing here in Lucknow. Hopefully, we cannot do it actually. We have lost our hope. In November was scheduled date. We'll shift it to next year. Anyway, because of COVID, we are not able to do it. So the challenges that time was policy, and the policy was taken care of by the government. However, in 2006, when user ministry came in, then the technological ministry, they withdrew the support. This is, see, now health ministry has come in, and they are the user ministry. Let them spend money so that deployment can start. Anyway, sometimes you have to be really forced to adopt something so that the support can be withdrawn and we can really stand on our own leg. So from 2006, we all become part of task force. We have several TORs in the hand, and we all work very hard. Different groups work very hard. Then we develop a document, all this thing. But the first thing that happened is in around 2010, 11, that when the Minister of Health really made some national projects. So in that, what happened in that intervening year of 2005, 2006, till 2011, the thing that has happened is in 2007, the government of Minister of IT declared our center. So by the time I am not talking about our center in Lucknow, it became a school of telemedicine. In
Oh,
2003, we
wow.
got a grant from our state government to set up a school of telemedicine. And in 2002, when the national conference was held, at that time the Secretary IT was here, and they announced to give 5 crore Indian rupees to start academic institutions for research development and teaching and training for courses. That's
Oh,
the
wow.
first declaration. And 2002 they declared, and 2003 state government gave fund to start a building. And till that time, the thing were going on in my office. And 2006, we had a first 2 floors of building ready. And 2007, the IT Ministry sanctioned our school, School of Telemedicine and Biomedical Informatics, the national status of National Resource Center in terms of providing some expertise. And they also allowed us to start some courses in telemedicine and biomedical informatics. So then in 2010-11, Government of India, Minister of Health asked for bids in terms of ideas how to really connect medical colleges. So then there are 3 agencies they presented on the invitation, and our proposal was accepted. And by the time, already National Knowledge Network has started. You might have heard about National Knowledge Network. This is
Yeah.
information knowledge, National Knowledge Commission was issued by the then Government of India, and it's a very ambitious project where
Yeah.
all the educational institutions were supposed to um, adopt this large bandwidth for and promote it for research collaboration, education collaboration, and conduct online courses, etc. and collaborative video conferencing, etc. So 2000 by 2009 or so, we already deployment in NKN. So now NKN .in is the site. You can see thousands of institutions have been connected. Precisely 1,500 or those days I have not reviewed recently, and that helped us to plan this project where every medical college has been given 1 gigabyte of internet bandwidth. 1 gigabyte.
Oh,
It's an
wow.
enormous amount of bandwidth. So now to piggyback on that NKN, so we proposed that we connect medical colleges, at least create a smart classroom in each
Mhm.
medical colleges,
Yes.
so that you can really collaborate leading institutions with them, and so student can get a good quality of knowledge and skill from different institutions. So this is called NK National Medical College Network, National Medical NMCN, National Medical College Network. If you go to the site nmcn.in, I'll send you some of the link of that. You can go through that. So there, 50 medical colleges have been connected regionally and making one center as a national center, that is ours. And there are many regional resource centers across the country. So that gave opportunity for what Latika was saying, to research collaboration or educational collaboration or clinical care. For clinical care, we created e-tumor boardrooms and all set to discuss cases of complicated cases for management of cancers, etc. And side by side, corporate hospital also joining, because they also develop medical tourism. As you know, that the medical treatment is cheaper in India, so they could get a lot of clients from Central Asia and from Southeast Asia and African countries. So they used
Yes.
to have the license office in those countries, and from there they can conduct video conferencing. So they could set up their own telemedicine network. One of them is Apollo Telemedicine Network Foundation, which is also a very big network.
Mhm.
Just like in US and Canada, you have many centers like that. They do individual corporate networks. So here, the Fortis Hospital, Naran Hidalaya, all these things, they are into it.
They are into it.
And I'll just take a little bit of time to discuss about the corporate initiative. Then, because business model of telemedicine are not there at all those days.
Mhm.
The
Yes.
two institutions, they showed how the business can be done. One is the teleradiology solution called Telerad in Bangalore. So he's a
Okay.
gentleman who has been American qualified radiologist. So he used to give consultations offline, because see what happens actually in US, the time difference is such, US
Mhm.
Canada. So the nighttime emergencies calls they can attend. So all
Mhm.
the radiology films from emergency source, they used to come to his center in Bangalore, and he's board certified, so he could give the consultation
Oh,
as a
okay.
radiologist. So he's a huge business he has done in those days. This is the only business model developed 10 years ago, and later on he applied that same principle for giving support to the Indian institutions where there is no facility for a radiology consultant, like northeastern part of India and other
Yes.
small hospitals. So
Mhm.
that is very business. I've gone to that place. This is a really good example of business. And looking at that business perspective, even the Narayan Hidalaya and also the Apollo people, they also started doing teleradiology solutions. So teleradiology is one of the big good business opportunities. Plus the teleconsultation, telefollow-ups of the patients by the corporate hospitals for their clients overseas. That became very successful in that. And government side, what has happened is the medical college network took over, and government had planned to how to reach out to the villages. That is the first. And as you know that down the line, our previous regime, the same government, previous regime, they introduced concept of digital India. In
Mhm.
digital India, health was one of the subjects those talked about, and they said how to reach out to the villages. But unfortunately, the challenge of connecting village was the rural bandwidth. How to
Yeah.
reach out to them. So if you remember, the telecommunication made a big change that time. They made a Bharat broadband. They
Mhm.
introduced a arm of our same telecom company of Government of India to make Bharat broadband, and they are given the task of going to the rural areas and spread fiber to at least to district level. And now it has been extended to village level also. This currently the program is to go to village level. And as you know, internet has driven the growth all around the world. So this is one of the example that is now showing the result. So the challenge of not getting access to health in village is now getting sorted out. I'll give an example about that little later, a couple of minutes later. But let me talk about a little bit of this policy, because the policy was very good to know, because that made the real driving of telemedicine. All the time the doctors get the excuse that we cannot cover license, or nobody's there to protect us this thing.
Mhm.
So when the COVID occurred, in fact we all caused COVID, but we telehealth people, scientists, they also
Yes.
appreciate COVID, because COVID
Yes.
has made people realize, shit, without telemedicine we cannot survive COVID
No.
times with all lockdown, etc. So that was the force multiplier, let me say that, which made everybody. See, do not, all these days, all the years we have been struggling to convince the government, to convince the office bearer, to convince the people, to convince the doctors, please adopt telemedicine, adopt telemedicine. All the time in any meeting we criticize and we get very bad name, we are criticizing the government. But 25th March is the watershed for the history of telemedicine in this country, where Minister of Health declared telemedicine practice guidelines. So this is
Yes.
not a law. The law takes many, many years to form, but
Yes.
they gave an addendum to our Medical Council of India law is a way of practice. So
Yes.
one way of practice from face to face, they said that, okay, we want to add another clause here to practice telehealth, which is considered to be part of the way of practice. That is the ethics. Of
Yes.
course, telemedicine law, etc. In US and Canada also, they are still struggling. Your Canadian health info way, still the struggle for this.
Yes.
Okay, Canada is much better. Canada is
Mhm.
much better in terms of the policy because they launched the info health way long ago and they're driving very fast. And you are much ahead of that. Australia is much ahead. What is happening in US because they are fragmented states. Every state has
Yes.
its own law. That's why it's not taken up that way. But
Yeah.
Canada and Australia, I must really appreciate. My hats are off for them. They have
Yeah.
really taken these policies far ahead, actually. That I have many
So,
good friends in Canada. They know how it has happened. We share all these things. Okay. So you want
Dr.
to say
Mishra,
something?
I'll just interrupt you because one of the goals I had to, talk to you about your experience in telehealth was to encourage a lot of people. A lot of my friends are there who are physicians in India. I want to encourage people to at least explore telehealth because given the COVID-19 situation, it has, as you pointed out, it has become so important that we have to think differently. And yes, telehealth has, gone through major leaps of, advancement in a very short span of time. So given the new, the 25th March guidelines from the government, what do you feel has been the major advantage? Because what I felt was the major advantage was we didn't have to bother with HIPAA compliant platforms and all that. We could use Skype or Zoom or WhatsApp. So do you think that was the major advantage of using this particular guideline? And the second question is, do you think these guidelines will remain like this long term, or do you think that after the COVID-19 situation eases out somewhat, these guidelines would change? I know you are not the policymaker, but you have had enough experience in this field to understand that.
No, I must say that whether there's guidelines or no guidelines, then this is going, this is bound to happen. People would
Hmm.
have adopted telemedicine through this way. Anyway, basically, what is telemedicine? Telemedicine is the next generation of telephonic medicine. So
Hmm.
previously, when this so-called technology is not there in transmitting images and everything through electronic means, that time we had the telecommunication. The first Graham Bell picture, if you see in the images in
Yes.
Instagram or village, you find that they're talking about, hello, Watson, how are you? I mean, that's thing. So it started from there. To the telemetry of the satellite navigators, so you have the astronauts. The NASA was doing that.
Yes.
So in 60s. So all these things happened. And so even before that, if you see the history, telepathy, what is all these things? That you think about something. So what I'm trying to tell you, whether the law is there or not there, this COVID has forced people, forced policymakers, forced everybody to reach out to doctor. Forget what this word telemedicine. They just want to talk to a doctor. They're desperate. They have nothing to do it. It is just like let's imagine a housewife staying alone in a city, even in pre-COVID areas, and the husband is away in business.
Yes.
Child develop asthmatic attack. What she will do?
Hmm.
So it's just like that. She has to talk to somebody to advise something,
Hmm.
right? So it is what I see that after looking at telemedicine for 2 decades, the guide or no guide, no law or no law, nothing is there, no video conferencing, I would have still practiced telemedicine. But certainly for us, we didn't want to just stay in COVID times. We want to see those rosy days where people should not tell, no, we are not practicing telemedicine because we are not protected by law. I look at that perspective, right?
Yeah.
Even today, if I hire a physician to sit and give a call center, attending call center of telemedicine, right? What is this enterprise telemedicine? I always talk it is a call center. It's
Hmm.
just like a call center, right? That's the
Yeah.
concept. right? I am putting paramedical workers in Canada and US. All chronic diseases are managed by nursing professionals, nursing practitioners,
Yes.
right? It is just like that. I'm instead of a person sitting there attending the call for British Railway in India, they're attending call of this thing. Had I been licensed to practice in Canada, I would have been giving consultation to your citizens there. Now
Yeah.
telemedicine, you'll find one day
Yes.
these barriers of this world of healthcare will change. Just like
Yes.
Indian or Vietnamese or Philippines giving attending call center for US services or British
Yes.
service or railways. Same thing won't happen to health in many years after this. What I know. So the point here I want to first question of yours whether these guidelines or these laws etc. has helped in definitely helped in for long run. It has helped in post COVID times also to continue and also in COVID times to make doctors convinced. Don't have to worry. We have a guidelines. Certainly it has helped us. And
Yes.
do you know, this has happened in 24 hours time. Just 24 hours time, the Medical Council of India submitted and next day it is approved. So that is the kind of you must call it, you may call it desperation, it's fine. But we have been talking about it. It's not that we're not talking about it. We're talking
Mhm.
about this licensing in a very forceful manner 2 years ago. When the Niti Aayog has formed, the Niti
Mhm.
Aayog was approached by us, our society wouldn't approach them. Many other people are fit, and they are the policymaker for the National Institute of Transformation of India, the Niti Aayog. So they also had in mind. And we are fortunately doctor there, professor there. He also understood this thing. So
Mhm.
for 2 years of persuasion is there, and I must say that this is going to happen. But this happened because
Yes.
something has given a force multiplier to do it, right?
Yes.
So that is going to stay. That's the first question. Second question, you tell me that, but I forgot again. What is the second question?
Second question I said is, do you think this was the, like, what should someone, let us say a doctor in the community who's not a part of an institution or anywhere like that, a private practitioner, for example, what should he be, looking for when he's deciding to implement telemedicine in his practice?
Yeah,
Because institution is a different story
understood,
altogether.
understood, understood. I understood your point. See, there are two way of looking at it. Okay, if you want to give support as a philanthropist, okay, I want to support.
Hmm.
I want to allow people to use my skill. So I want to donate my knowledge. I want to really help
Hmm.
people at distress.
Yes.
You are there, announce it. That
Hmm.
okay, I'm available at this number, this time of hour, I'm available. You can say I'm a pediatrician, I'm a radiologist, I'm so and so,
Okay.
I'm a general practitioner. I can be of any help to you. Please contact me this number, this time. I'm okay.
Hmm.
Fine. Just with a mobile phone, you can be accessible, right?
Okay.
Even no, as I told you, there is no kind of no barriers in transmitting information. Health
Hmm.
information can be exchanged
Yes.
like you can take a snapshot. I don't have to tell you. Your kids also know how to
Mhm.
exchange the image, how to exchange the video. All these things are possible thanks to technologies. These are all free now.
Yes.
All these companies have made everything free. Though little bit of problem has occurred because of licensing, why the government has created some issues. So okay, but besides that, if one is not allowed, there are so many others are there in the market. So that's not an issue. So you can do that. So one has to really say that okay, I'm available. Whether it is individual, whether it is
Mhm.
practitioner who wants a monetary benefit, all fine. Nowadays, you say that okay, I'm available on for some price. My charge is this. Go
Yes.
ahead and do it. Nobody will stop you. Okay, government has
Mhm.
not approved your fees, etc. But in practice guidelines, it's all built in, right?
Yes.
So you can charge your money. You can now this payment of money is very easy nowadays. It
Yes.
is not. It is
Yes.
not today. Even pre-COVID time. Let me tell you some
Mhm.
examples. There are many companies in India. They give services, right? Using this enterprise video network, like Portia in
Yes.
Bangalore. So
Yes.
they give services for rehabilitation of people. It is just like
Mhm.
calling a plumber. Like it, you are living in Canada, know very well.
Mhm.
I had a little experience in Britain where you just call a gas person, you get a plumber, they give appointment, and they have per hour charges, and they'll come
Yes.
and attend. Very effective system. Nowadays, people are ready to pay money.
Mhm.
Today, even in India also, not everybody, but many people have the capacity to pay money, right, for
Yes.
a service to be given,
Yes.
right? They are fine with that. Whether government law is not there, still see private practice is covering 60% of our Indian healthcare system.
Yes.
How
Yes.
it is surviving? Because people are
Exactly.
cooperating. They're ready to pay money. Whether
Mhm.
it is a small time practitioner in a small tehsil or block to the Apollo Hospital or big private hospitals existing in the country. There are plenty of them.
Mhm.
They're no way different from any of the hospitals of your country or in North
No.
America. So,
Yeah.
so my point is, anybody everywhere who is practicing, even if you are practicing in Apollo, you practicing in Fortis, any other corporate hospital, still as an individual, after your off hours, you can still offer your services. Whether
Mhm.
you charge money or do philanthropies, all are welcome. You are covered with licensing. That much, let me tell you, assured that telemedicine practice guidelines gave me the immunity
Yes.
right? At
Yes.
the same time, by law, by the Hippocratic oath, I'll try my best not to do any mistakes. That is
Yes.
my, in spite of doing good work, still there can be some mistake somewhere, but that is pardonable under the law, right?
Mhm.
Whether it is face-to-face consultation or electronic consultation, there's no difference at all.
There's no difference.
Anything you can do. You can remotely monitor an ICU. You can remotely monitor a person doing a procedure and give an
Mhm.
impression. Everything is possible with today's technology. So technology is not at all a problem. There's no
Yes.
limit to that. You have to extend. Just imagine 20 years ago, with those kind of barriers, one can do something, right? One could do something. So now also with so much facility available, you don't have to do anything. You just do it at your fingertip. Your mobile phone is your driver. That
Yes.
will drive you anywhere you want, right? That's the second question I have answered to you. So I have one more 2 points to just tell you what is happening here in my situation.
Mhm.
Now,
Yes.
during COVID time, I'll give you a little case study of our state, what I've been doing.
Yeah.
Uttar Pradesh is a very large state, right?
Mhm.
It's a very large state. So what the government has done is electronic COVID care system. It's called ECCS. I'll
Okay.
send you the link of ECCS.
Okay.
So if you go to my website of our institute, sgpgi.ac.in, you will
Yes.
see there is COVID link. Go to
Okay.
COVID link, you will find the ECCS.
Okay.
How we have done ECCS. And one is called EOPD. So
Mhm.
ECCS is entire UP has been divided to 3 zones.
Okay.
So we have like administrative wise, we call mandal. So it is six, total 18 mandals are there. Under one mandal, there are several districts, several medical colleges, several hospitals. So they divided the hospital into L1, L2, L3 level, right?
Mhm.
And everywhere there is COVID care systems. So they made 3 leading institutions of the state to cater different zones. So
Mhm.
for example, SGPGI was made an advanced CCS ECS hub, and we are given the responsibility to cover the entire Western UP. Institute
Okay.
of Medical Sciences in Varanasi were asked to cover the entire Eastern UP,
Okay.
right? And King George Medical University in Lucknow was asked to cover the central part of the state.
Okay.
So, so these are broadly divided to them, but anybody can access anybody. There's no issue,
Mhm.
right?
Okay.
For that, telecommunication is not a problem at all.
Mhm.
Everybody can get the access to telephone and internet and everything. We have WhatsApp mechanism using mobile phones. Everybody is declared. If you go to the site, you'll find everything detailed in that. So everybody has gave announced numbers of the EOPDs and
Okay.
ECCS. So mostly EOPDs ours in SGPGI, but others have ECCS. So
Mhm.
there are doctors from multiple specialties to answer the questions. There's a fixed time from morning 8 to night 8, so they can
Mhm.
give consultation on surgical, medical, all
Oh,
specialties,
that
and
is
also
fantastic.
and yeah.
Mm.
So it is L1, L2, L3 level of hospital. A difficult case, you can go to a higher place. And in the ECCS network, we also add something like continuing medical education. That also we have added from a GPGI side to discuss about topic related to COVID, how to manage the
Mhm.
complication, how to manage the ventilator apparatus. Then
Okay.
non-COVID during COVID times. That
Mhm.
is another area we should not neglect.
Mhm.
Like
Yes.
we, we,
Absolutely.
we do it every 2 days in a week, at Wednesday and the Saturday. All our partners are connected again through Zoom, and we share some of these faculties lectures to them. Very practical points how to manage that,
So,
right.
Dr. Mishra, I'm just interrupting you. This only available to people in Uttar Pradesh, or doctors from other parts of India can also access it?
No, this is available only for the Uttar Pradesh, and because in India health is a state subject. So
Yes.
every state and but this kind of it's not in the exactly same, but other states are also doing
Mhm.
telemedicine in their own way. But
Their own.
telemedicine is there because OPD is closed. They have to give
Yes.
service. So,
Yes.
so that they are doing it. So every state is doing, but I don't know their model. So
Yeah.
actually, we are doing a survey now to find out what is happening where, what kind of model they are doing
Mhm.
it. In
Exactly.
fact, we have planned to do a national conference virtually to get
Mhm.
experience from different states, what kind of
Yes.
things that they have done,
Yes.
and moreover, what is the impact of that? What kind
Exactly.
of study they are doing to
Mhm.
do the analysis, what is the impact of that? The second point I want to say that EOPDs. So
Yes.
same site you will find. I'll send you the link. EOPD is all the departments, as you know, our regular OPD is closed.
Yes.
So earlier we allowed only the emergency and STEM emergency departments to be open. Now we have
I'm sorry, the audio has disappeared. Um, Dr. Mishra, I'm not able to hear you.
Video.
Hello. My apologies for the loss in connection. Dr. Mishra, the connection just got disrupted just now.
Can you hear me now?
Yes, I can hear you now.
Okay, so fine. So I will talk about little EOPD. So
Mm-hmm.
I told you about ECCS.
Yes.
ECCS is, I told you this how they are being covered only for COVID-related issues, but for our own patients, like
Mm-hmm.
our own patients, old patients, or new patients want to contact. So earlier we completely closed our non-COVID systems unless there
Mm-hmm.
is an emergency, right?
Yes.
But now we started our things even from the month of May. So now it is 2 months going on, and we just covered 2 months. And in that, 26 our clinical departments, they come to the school of telemedicine where you have set up
Okay.
EOPD facilities. And in
Wow.
that, so one medical social worker and one consultant is sitting there along with the residents, two or
Okay.
three residents, and these numbers are announced to people. In the website, you will find out exactly what
Okay.
I've been doing. All the numbers have been announced in the newspaper as well as in the website, and by the government they've distributed to all over the country. So then they access from 9:30 to, it's open up to 9:30 to 1:30.
Okay.
The EOPDs of
Usual
SGPGI.
OPD hours, yeah.
Our old patient, or anybody wants to show it to us in
Okay.
SGPGI, right? Like for example, a new patient can also be registered if
Mm-hmm.
he's a emergency case, like somebody has cancer breast, or
Yeah.
somebody has large goiter to be operated early. So we take up on urgency. Somebody has a priority, not urgency
Mhm.
exactly, priority. So we
Right.
cannot wait,
No.
because by doing more and more work, you are exposing all healthcare workers to the risk of
Yes.
COVID. And
Yes.
there are a lot of problems for the patients to get undertake any routine surgery or routine intervention, because they have to carry COVID report from outside,
Mm-hmm.
then for attendant one COVID report,
Mm-hmm.
and only one attendant is allowed with photo ID. So a lot of restrictions. So, and the cost of procedure has gone up by 20-30% because you have to put the PPEs.
Mm-hmm.
So if
Yes.
surgery is done, then the anesthetists, nurses, attendants. So
Yes.
we use so much of PPEs, so they
Mm-hmm.
charge to the patient, right?
Mm-hmm.
So we discourage them to and request them to wait if they can wait. So
Mm-hmm.
this is our EOPDs for surgery, and medical departments are very good because they don't require such kind of investment.
No.
So they are very good for managing diabetes, gastrointestinal problem, and any patient found in the during course of these EOPDs consultations, they are called to be admitted as a priority, whether it
Oh,
is non-COVID emergencies or non-COVID routine also. So that is
oh.
EOPD that we are running. I'm sure in other institutions also they are running such kind of service.
Mm-hmm.
And what will happen after COVID for this? I'm sure, because now everybody has realized, everybody realized there is a benefit. So I'm yet to do the impact study, but I have done offline talk to my colleagues.
Mm-hmm.
They all say, oh, this is fantastic. We'll continue with that only. All
Yeah.
our old patient, because they don't want a crowd.
No.
So how they can do it? All of them are now the same faculty member who used to never visit our telemedicine, never in all these 20 years. They are all here, so encouraged, and I'm so obliged to them that they are also convinced. No, it has a potential, so
Yeah.
I'll do it actually. That's
Yes.
one thing. So that is the advantage that COVID has made for people to realize. So the challenge is what I feel, the adoption in the health system, that is going to easy now.
Mm-hmm.
Now all the governments have realized, oh, telemedicine is going to stay, and it has shown the benefit. So my next part of this thing, challenges, and let me tell you, some challenges are being taken care of, and we
Mm-hmm.
hope that this will translate into the policy. Like unless any health system is adapted to the health system, it's not going to work. If it's a
No.
public health system,
Yes.
public health system, and as you said, for example, solo practitioners, when they announce, then definitely he or she will get clients,
Mm-hmm.
whether it is for monetary benefit or philanthropy.
Yes.
Everything is going to work. So whoever is practitioners, your friends are there in India, let them announce local newspaper. I am available for a fee, and develop. And there are now companies have come up. Another thing
Mm-hmm.
is the business model of telemedicine has really come up now. Now there are several companies. They are offering the entire solution for you. Okay, you are interested. You are interested. You are interested. Okay, I'll make a group
Yeah.
subject wise. You are a family physician. We are general practitioners. You are a
Yes.
gastroenterologist. They may classify. All these things are now going to business model is going to work actually very well.
Yes.
So I have no doubt the telemedicine is going to stay and remain
Yes.
part of the health system. Number two point I've written, challenges business model. So no services run in an enterprise manner without a business model.
Yes.
So, and this is going to business. Telemedicine is going to business in the near future. I'm sure it is going to. I'll see that thing before my departure from this world. The third thing is the stakeholder awareness. The stakeholder awareness, who are stakeholders in health? It is after all the patient.
Yes.
We are there for the patient. So demand and supply, that is the basic principles of any system, right? To survive.
Yes.
So I am very hopeful that telemedicine is sustainable. There's several research papers how to make telemedicine sustainable. Don't have to do anything. No research is required. It is just, it's
Yes.
going to happen. Sometimes things going to happen. This will just happen, right? That's
Yes.
the kind of thing that is going to happen. The third thing is ethics, social, and licensing. All these things are again the morality, ethics, everything has gone down the drain now. Now
Mhm.
all those doctors who those days are telling me, no, how can I talk to stand in front of a computer and mobile phone and talk to a patient and all these things. No, how they'll quote it. So whatever you do, there are plus and minus side of technology. You
Yes.
all depends. So we cannot make this world a very crime-free world, or you make a completely very clean world. It's going to happen. When there is a technology, when there is benefit, there's always two sides of a coin.
Yes.
Happiness, sadness. They're all two sides of coin, right? Internet has brought us so much benefit. At the same time, internet has so much disadvantage. So people want to do crime, they'll do crime. People want
Yes.
to do utilize it in the wrong way, they'll do it the wrong way. So should we stop it? We're going to travel in the road, there's going to accident. Should I stop traveling? And that's the way I look at my life. So
Yes.
that's the way I think people should think about that. Insurance coverage already has started. In fact, in India also, I have just been seen some newspaper articles. Some we don't have many insurance systems here, but whatever they're there, they have now started accepting these things as one of paying model. Then they, of course, in US and North Canada, I'm sure there are already many. For many services, they allow it, like
Yes.
for diabetes care, especially NCDs and all these things,
Mhm.
like Blue Shield and other companies. They are all giving now services. Next is the rural penetration of internet. This is a challenge that I want to talk a little bit about that.
Mhm.
See, rural penetration of internet. You just cannot say Canada and America are very advanced countries. No, that no problem. They can reach out anywhere. Even now
Not
also,
really.
even now also, in
Yes.
now also, Newfoundland, you cannot
Yes.
reach out. You cannot
No.
reach out,
No.
right? And in America, the Federal Commission on Communication give grants. Oh, practice rural telemedicine. They're getting huge amount of grants. They give it to all those institutions and universities. Do research, do practice these things. So I know they have these many resource centers in America on telemedicine. I'm in touch with them. So they get huge amount of money from the Federal Communication to develop models for
Mhm.
rural telehealth. All government, this is the agenda. How to give a health is a very sensitive subject for any
Yes.
politicians for this thing. So everybody wants it. But unfortunately, we have not shown the benefit of terrestrial line to reach out there. Now, all the mobile broadband internet providers, they also could not provide this access
Mhm.
because they don't see much of business in the rural areas. They
Mhm.
will only invest in those areas to create infrastructure. They raise the towers and everything. But where is
Mhm.
the return?
Yeah.
Just for health will do. But what I feel, in addition to health, now the education has come into picture.
Yes.
So maybe for health and education
Health and
and accessing information, that's
yes.
another thing also. So the
Yes.
so-called e-governance is now taking a different shape. So now I'm hopeful that these companies are going to really invest money in rural areas, and there is going to be a big return for sustaining a business. And the thing that I wanted to tell you about these things, that the new technologies like 5G, etc., is not
Mhm.
making much difference as far as practicing telemedicine. The
Mhm.
4G is good enough.
Good enough.
4G is good enough, and I can see the mobile broadband internet has a lot of scope in propelling telemedicine in rural areas. Then another aspect is smart city. That is also coming up in many countries. Smart
Mhm.
cities. In
Yes.
smart cities, health is one of the big thing. Every household, it
Yes.
is a kind of political slogan. Every household get pipe water supply. Every household get power. I
Yes.
remember one of the scientists talking about decade ago. They see electrification is a sign of growth. You
Mhm.
know, they said once there is electrification, some say that when there is a road, once there is a railway line, there is
Yes.
infrastructure. It is just like, in master plan of any city. If somebody is trying to set up a big housing complex there, then the land price goes up. So it
Mhm.
is just like that.
Yes.
I feel, irrespective of 5G, okay, 5G requires some higher versions, no? Like,
Mhm.
like I want a very good clarity for a life surgery transmission, etc.
Yes.
So that is okay. But for routine practices of telemedicine, when you have shown in Africa, just short messaging service, SMS, has
Yes.
made tremendous change in
Mhm.
behavioral health problems, right?
Yes.
So if that can do with just a feature phone, which gives an audio as well as SMS, why not this internet is going to make a change if only a WhatsApp video and all this thing happen? So I'm very, very optimistic that the telemedicine really going to fly in
Yes.
coming years. So this rural penetration has to be taken care of by the government to see that the business companies that they invest money there and provide mobile water. No scope of terrestrial. We should not
No.
invest money in terrestrial business because that is very difficult to maintain.
Yes.
Right? Many of these companies of government are getting closed because they cannot really support the sustaining this company because the competition from private is so much,
Hmm.
government cannot match. So I feel that entire telecom business should be taken over by the private companies, and people are now ready to pay money if they good
Yes.
service.
Yes.
Everybody doesn't matter. They
No.
take all kinds of packs of mobile internet companies
Mm.
and they keep on adding those packs. And that's all I wanted to say. That for specific questions on this, I will take it up.
Thank you, Dr. Mishra. So just a few practical questions from point of view of a practitioner. I know you have a lot of research papers on that. So in implementing telemedicine, teleconsultation for the patient, one of the challenges that I have personally faced as well is doing a physical examination. I know you have followed up your surgery patients through teleconsulting. So will you share a little bit about and the amount of money they could save because they didn't have to come and visit you? One of your papers has the numbers, I think. So will you
Yes.
share a little bit about follow up of surgery, like the wound care? How did you find it a challenge to look at the wound through a camera, and was that as good as it would have been had the patient visited you in person?
I think you have answered your own question. So you see your mobile phone, see your mobile phone cameras, how
Mhm.
powerful it is. See
Yes.
your, we are just doing a video conferencing. We can see each
Mhm.
other very well,
Yes.
right? So there's no doubt you can see any wound, anything. See,
Hmm.
I'm a thyroid surgeon. I can see your neck so clearly. If there is a scar infected, I can immediately diagnose, no problem at all. I
Yes.
can see a swelling there. Even a pre-operative patient I examine, I just tell
Mhm.
the lady to swallow. I find a thyroid nodule moving in the neck. I can diagnose, no problem. So there is no limitations of clinical examine. Of course, if you want to see the liver is enlarged or not, I need a help of a physician there. Okay, assisted physician, I can ask the general duty medical officer, kindly just check the liver.
Mhm.
Or somebody has something to show it, like for example, examining a breast for a lump. I
Yes.
cannot do it remotely, so
Yeah.
I'll take the help of a local doctors to help me that. But is not that acceptable? That
Yes.
the doctor layer. That's what I've been doing there for non-operated patients. They
Mhm.
want my support as a specialist. So they examine and demonstrate me. This is the thing. We maintain the privacy there.
Mm.
So there's no issue at all. They can examine the breast and tell me what they're finding, or they can examine the breast in their office room and tell me the findings. It's enough for me. Diagrammatical, they tell me is okay. The lump is in the upper outer quadrant or something like that.
Okay.
Nipple, there are the graphics pattern in the medicine.
Mhm.
You can show the nipple erosion, all these things you can show it. That's not issue at all. So
Mhm.
I find personally that majority of cases we can do without a physical examination.
Yes.
But for minority cases, you can take the help of local doctors to help you out. That's not a problem. And the amount of money saved. So I started follow-up of patients many years ago. I started with telemedicine specific equipment systems with a traditional video conferencing and everything, which has a pan tilt zoom facilities,
Mhm.
expensive setup. From
Yes.
there, I moved to Skype using. I'm requesting the patients' children. Please tell your children or your grandchildren to connect a computer in school. They're teaching them computer, so they can connect and I can interact with them. Now I have reached a stage of WhatsApp. If my last paper is in WhatsApp, so if you compare the previous paper and now paper, is WhatsApp. That is just you're quoting in the WhatsApp. Everything is gone. It's just a mobile phone. I don't need anything. Patient
Yes.
from home. It is just like telehome care, right?
Yeah.
So in that paper, what I've highlighted that with that I can see the wound. I can get the findings of the thyroxine hormone report. I can adjust the dose of thyroxine. So all these things I've shown in that paper actually. And it's not the only paper. There are several papers that similarly have happened to many
Yes.
countries. Surgical application, always people, no. You have to see the wound, see this thing, all this thing possible. Now the powerful camera that has come up. Now do you get a 4K cameras in the mobile phone? Your mobile phone has become very powerful. Even if you don't have an expensive phone, a basic
No.
smartphone, it
Yeah.
costs hardly a couple of dollars for you. You can
Yes.
afford that. So now in my, the laborer here also carries a smartphone. Though it is made in some countries,
Yeah.
cheap sets are available, but people
Yeah.
are. I mean, I found if you read that paper and read similar papers in the web, you will find that no restriction. People are accepting it. That is what is important. I'm spending so much money. Many of my patients come
Yes.
from Odisha because I'm a native of Odisha. So I get a lot of patients from Odisha,
Mhm.
So now they don't send me. I get patients from Bengal. So they just don't have to come. And do you
Yeah.
know what made me to accept WhatsApp? Previous to that, I used to do Skype, for which a
Yes.
computer has to open, internet has to be there. And this gentleman asked me, Dr. Saab, can I not send my report through WhatsApp? You see, the patient is teaching me what it is. You must have heard as a doctor, you must have known, diagnosis is written on the face of the patient.
Yes.
Half of the diagnosis is made listing the history.
Yeah.
I have not said it. It's
Yeah.
all my forefathers have told it, right? All
Yes.
our great grand teachers have told it. Listen history carefully. Observe the patient carefully. Those the art of patient examination is gone with the current generation of doctors. They just see for everything CT scan, ultrasound. Unfortunately, I didn't have the CT scan ultrasound during my interning days. So, so the things have changed, but the principle of medicine has not changed. We
Yes.
still need to observe. You can
Yes.
still examine the patient while converse with the patient. You'll find patient in distress, patient having pain. All
Mhm.
these things can be watchful. So visual media has a tremendous capacity to us. Now, technologies don't have to be mastered. The
No.
patient teach you technology. The patient gives you the way. Like this patient attendant told me, he's from Kharagpur or something. Doctor, can I just send my report? I want to adjust the dose of ultrasound. I told him, can you go to that center? They have a telemedicine facility. Then he told me, do I need to go to that center?
Yeah.
I have this WhatsApp video, and that time WhatsApp video is not there. It is
Not.
only WhatsApp transmission of this thing. So can I not transfer this thing? Can I not take a snapshot of my wife and send it to you? Can I not take a snapshot of the wound and send you? Just
Mhm.
imagine diabetic foot
Yeah.
infections. Don't you think this can manage by the snapshots?
Yes.
Even a day-to-day practice, when I go to the ward, this resident has already dressed the patient.
Hmm.
By the time I go, he's already finished the dressing. Then I should tell him, how come you didn't wait for me? No, sir, this is the wound. You can have a look at it. So see, what is it's all technologies made
Yes.
this difference altogether. So I feel the telefollow-ups for anything. Now the entire ICU is getting telemonitored.
Yes.
The entire remote patient monitoring systems. You can
Yeah.
monitor a patient from the home, right?
Yes.
All the geriatric patients, we can monitor the home. From
Yes.
nursing homes, in your setup, there are nursing homes.
Mm.
I had an idea. I'm looking for a real estate company who will accept my idea. I said that whenever you make a house, complex, just
Hmm.
give me one particular small room to develop a teleconsultation facility. So entire 200 people or 50 people staying in your
Yes.
real estate, they can cater this thing, and they don't have to come to that place. You
No.
connect a network to, like you put a security phone
Yes.
camera in the everywhere. Just add this facility. They can directly put the hub there, and
Hmm.
we can give the service here. And this is going to
Yes.
come in near future.
Yes.
There are
I
dedicated,
fully
there
agree.
are there are dedicated housing complexes happening only for elderly people.
Hmm.
Elderly people also stay in our country. There are many religious places where very elderly people they go and stay there in the last part of their life, so they can get well connected to that. So there
Yeah.
is no, it's like a connected health wherever you are. Just imagine you have gone to holidays, some remote place in the
Yeah.
jungles, you know, and you need some problem. There's some problem. What to contact? Even those research should have a facility for, or they empanel some doctors.
Yes.
Every hotel has empaneled doctors to give
Mhm.
service. Okay, so instead of physically coming or physically calling the patient, you just connect them. If required, they'll come. Otherwise, 90% of time, this emergency condition can be managed.
Mhm.
So that is the way. That's the way actually how look at it is.
Mhm.
I feel we have to be very open. Now with the COVID time, I always said COVID has many negative points, but there are some positive points come out of this. It has made us to think. It has
Yes.
made us to think. Please close your eyes. Just imagine if telemedicine is not there,
Not.
what would have done?
Yes. You're so right, Dr. Mishra. Another, just because we are almost we've run out of time, one more thing that the new document which came out in March suggested that all these consultations have to be recorded. So I know that at your institution you're using EMRs. Now EMRs usage is not there, so electronic medical record usage is not there all over the country, I know that. So that, do you think, because there are a lot of companies who have come out now with this system, which is very easy to record now, because earlier we used to, patients sitting face to face, writing it in pen and paper. So do you think the adoption of EMR is the other thing that would be sort of like, and again I'm talking from the view of a private practitioner because I'm not a part of any institution. So do you think that would be a factor as well? So cost is of course a major factor in India always. So using an EMR and implementing an EMR, do you think your institution, I know you're already using it, so that's not a problem at all for you.
Uh, to be very specific, yes, I agree. We should have a EMR for all health
Yeah.
exchanges. It is not only for the solo interaction, but for NCDs where you want a,
Yes.
long-term data to know at the comparing the previous blood sugar or previous
Yes.
blood pressure. EMR is very good thing. But thing is, uh, besides the legal part, see, recording of all these transactions has to be done. Ideally
Yes.
speaking, if you're,
Yes.
especially if you're charging,
Yes.
you are charging because we are covered by the government insurance system.
Mhm.
I am doing for the government, so I do not have to have a recording of everything unless government
Yeah.
provides that option, right? But
Yes.
if somebody is having business model and when you're putting a charge,
Yes.
then it has to be recorded. Number one. Number two, electronic medical records give the opportunity to record the events and findings.
Yes.
Otherwise, there is no other media because no question of writing a piece of
No.
paper. No, it is
No.
our electronic prescription which electronic signature has to go.
Yes.
So EMR is a must, I must say, and recording of the video is a must.
Mhm.
But who should do the service? It is not
Mhm.
you who can do it actually. Though you have the option of recording everything, but why should you do take all these things?
Mhm.
Because you have so many patients to see. It's not possible. It's not only capturing something, but you have to maintain that, manage that. So
Yeah.
there are many companies coming up now. They give these services. They
Yeah.
have their own cloud systems.
Mhm.
They give entire solution. They give the EMR, they store it, the
Yes.
videos, data. They have different business models. So you want to only capture a video, you want to only capture the data. So all these
Mhm.
options are there. And I know in Indian companies, actually, many things have come up. Now, government of India also has made another systems where you can create a record, and
Mhm.
they offer it also to store if you are giving services free of cost, like e-Sanjeevani. It is a
Okay.
software called e-Sanjeevani OPD
Okay.
online.
Mhm.
I'll show you all the links in the email
Okay.
in a couple of minutes. So
Okay.
e-Sanjeevani OPD online, if you see
Mhm.
that, so what they do is it is in the cloud.
Mhm.
So you want to start a interaction with the patient. So the patient has to download that, right? And they connect you, and it will come to your mobile phone or your laptop, whatever it is. And there are points to record. So first patient has to record. A very simple two-page system, so you can fill up your demography, complaints, what other things are there, temperature, etc., problems, and then you answer that. And that answer is also recorded in that same system electronically, and
Mhm.
it goes to the cloud,
Mhm.
right? Patient gets to know what the patient see your video. It is all video is built in that, and so you can show the directly. So what I can do is tomorrow is Monday, so I can actually timings are not suiting actually.
Mhm.
So I can send you the process how it is being done. I told so we have set up a like a call center from
Okay.
9:30 to 9:30 to 5 o'clock. There are five general duty medical officers. They're giving service to the health and wellness center. So I did not talk about health and wellness center. In two
Yes.
minutes, I can finish it up. This health and wellness center is part of the Ayushman Bharat. This is a government initiative of
Okay.
government of India, and they are implementing this project with the health mission of the states. It's
Okay.
called the National Health Mission.
Mhm.
So they take care of the rural access of sub centers. The sub
Mhm.
center is below primary health center,
Okay.
and they cater to population of 5,500 people. Now here there's no doctor. There's a community health officer, CHO. This
Okay.
community health officer is a trained graduate of nursing who has been put in the bridge course for 6 months in one
Mhm.
of the institute in Delhi, National Institute of Health and Family Welfare. So they train them in 6 months, basic medicines services to give in, and they have been given a license to give 50 medicines. This is listed
Okay.
actually. This medicine
Okay.
provided to them,
Okay.
and on the advice of a doctor, they can issue
Mhm.
this medicine to their
Okay.
patient. So
Oh.
this is the model. 150,000 sub centers are supposed to be enabled with telemedicine.
Oh
There
wow.
are also other things to do. They will do other things also. They have been given the responsibility to give many of the public health initiatives. It's
Mhm.
basically for health prevention and health promotion. That is the WHO definition of health.
Yeah.
So instead of care, you also look after that because that also prevent a lot of diseases
Mhm.
or monitor a lot of diseases. So here, these people are really going to make a lot of change. 150,000 is a very ambitious project of government of India. And the other part of Ayushman Bharat is the insurance system. That poor
Mhm.
patients are
Yes.
under particular income, they can be given some certain amount of money for
Oh,
getting care in institution. right? So all the institutions, whether private or government, they're supposed to give the service, and this is the amount for thyroid surgery, this is the amount for breast surgery, this is the amount for stay hospital. So
Mhm.
there are charts and everything government has provided, and this is good. This 150,000 sub-centers will be equipped with telemedicine. For that, the model is one of these medical colleges of the state. They have made many medical colleges as a
Mhm.
hub, and they have been given responsibility to so many sub-centers in so many areas.
Mhm.
Just like same thing as ECCS. So we
Yes.
have been given 80 nodes in this particular districts. So our 5 doctors are sitting from 9:30 to 5 o'clock and giving these calls, backache, headache, all these systems, right?
Mhm.
And they also contact the nearby PSC or CSC also
Okay.
for consultation. And some of the calls come here. And we also have option of some specialist, they're given some money for that. So you can get some specialist from mental medicine, gynecology, pediatrics,
Mhm.
or any other specialty in demand. And we pay them 3,000 rupees and for the services they give from 9:30 to 2 o'clock.
Okay.
For certain slots are there.
Okay.
And but these medical officers are given 60,000 rupees per month. And their
Mhm.
basic medical services like MBBS, they
Okay.
give this fast call
Oh,
response. So
that
this
is
is
very
really when it happens actually, we can have tremendous impact
yes.
on the health and wellness. That
Yes.
is very important.
Absolutely. Yes.
Prevention and wellness is important factor.
Yes.
Many of
Yes.
the NCDs can be really prevented or can be managed properly. Like a diabetic, diagnosed once, finish, no monitoring. In the
Mhm.
villages, who cares for this thing?
I
They'll
know.
end up in some complications.
Yeah.
Here, one can make a see if you want to really exploit this system, we can really train that CHO to maintain the database of
Yes.
all diabetics within the jurisdiction. So I
Yes.
have some ideas to work on. Let me see, let it mature. I have some ideas to work on NCD to creating database and all those things. So that's the last thing I
Thank
wanted to
you.
say. I think I covered
Thank
everything.
Dr. Mishra. One clarification I just wanted to ask you. So, from the document that the government came up with in March, what I understood is the consultation has to be recorded. So, it doesn't mean that the video recording has to be done. Am I right? Because video recording, if we are saving it on the cloud, then the HIPAA compliance and privacy and everything comes into it. So what I understood is if we are recording that consultation on like an EMR or some kind of a secure system like that, we don't necessarily have to record the video and store it. Am I right in understanding that correctly?
Yeah, I mean, they have not given that much of importance on
Yeah.
this video
Yeah.
recording. They are not mentioned at all actually about that. But what I said specifically, if you are practicing as a business model,
Yes.
see, as far as you are covering in a state health systems, no problem, right?
Yes.
But if you are in a business model of telemedicine,
Mm-hmm.
I think when people are paying money from their pocket, they will
Mm-hmm.
also demand if some Mishra for compensation.
Yes.
Remotest possibility. Even if it happens 1 in a million, then it is a case.
Mm-hmm.
So I suggest if some companies are approaching me for this thing, I tell them that if it's a business model, it's better to you protect these things at yourself.
Okay. Mm-hmm. Okay. Yes, that was something that was a little not very clear in the document because some people understood that the video has to be recorded and then storing the video is a big problem if it's a private practitioner. So
And
that
that part is not that part is needs to be again addressed. This is
yes,
the document which has been released
yes,
first edition. There
yes,
can be several amendments. So what sometimes we think that let us release the first version.
yes,
Let it be uh, let it be really addressed by people who are practicing it.
yes,
Right? Let some problems comes up. Okay,
yes,
then you can address these things. That's
yes,
another way of looking at it. Because no system is perfect. You have
no,
to make it perfect.
yeah,
So how to make it perfect when the stakeholders are involved,
yeah,
right? So we have to, I think, look at it in a very open way.
yeah,
And see, in day-to-day practice also, at least we don't get so many litigations issues, at
no,
least in our country, right? If you are very honest to your system
mhm,
and patient, you talk to the patient quietly, patient convincingly, and listen to the patient carefully and satisfy the patient. I think 1 in a million you may get a case.
mhm,
But that again, I told you, you do have to stop riding a car if there's accident. I mean, this is
yeah,
going to happen.
exactly,
It can happen in any profession,
yes,
and we have to take it in that way. And as far as law is concerned, I'm not an expert. I just want there has to be some system where people should not ask me, no, we cannot practice telemedicine because there's no law. At least
yeah,
that part is taken care of. So
that
that's why we
part,
are very much indebted to our government to launch it. And I always believe there is a time for everything, time and place. It's a destiny. It has happened. We should be very
yeah.
happy about it.
Thank you, Dr. Mishra. That was fascinating, and really, your experience is going to help a lot of people. Thank you very much for investing your time with me, and I'm sure a lot of my colleagues, our friends, and a lot of people in general will benefit from this information. Thank you, and bye now.
Sure. Now, bye bye.